Wonderful. That was fantastic, Bob. Next will be a didactic pathology presentation, as was introduced by Bob Anderson, and this will be by Diane Spicer. And Diane is a senior morphologist at All Children's Hospital in St. Pete in Florida, and also the curator of the Ludwig van Mierop Archive at the University of Florida in Gainesville. Diane, welcome.
Thank you, Jackie. Do I change my slides on with the mouse or the? Okay. All right, thank you. So I have no disclosures. Today we're going to talk about the functionally univentricular heart, and these terms in the past have been quite controversial, both for the clinician and for the morphologist or pathologist. The term functionally univentricular heart is now used to better illustrate the differences in this group of patients that I have listed here with these types of congenitally malformed hearts. In this group, they usually have one dominant ventricle and one small ventricle, and it's usually not possible to surgically correct the hearts to achieve a biventricular circulation. In the past, there were a lot of controversies with this topic, especially early on when I was training here at the Children's Hospital of Pittsburgh. So when we talk about a true single ventricle, it does occur, but they are rare. They are solitary and indeterminate, have a double inlet and a double outlet, univentricular atrioventricular connections. The only septum present in these hearts is the muscular outlet septum, and they typically resemble a morphologically right ventricle in that they have very coarse trabeculations. This case usually occurs with isomerism of the right atrial appendages. So both for the clinician and the pathologist, the diagnosis can be difficult. So these are two examples of solitary and indeterminate ventricles. And to your left, you can see it's viewed from the apical position and has a common atrioventricular valve. And this case did have isomerism of the right atrial appendages. The image on the right has separate right and left atrioventricular valves, and there was usual atrial arrangement in this heart. Both have a double outlet, and you can see that the outlet septum is the only septum visible in these specimens. So in the past, there were some controversies, as I've already mentioned, associated with the criterion that defined a single ventricle. The definition to define a single ventricle in the past used to be having a double inlet with an atrioventricular connection, and most patients also had a second smaller chamber, and that chamber in the past was denied ventricular status. And it was considered only to be an infundibular outlet chamber, as Professor Anderson already mentioned to us. Hearts with tricuspid valve atresia were accepted as being biventricular with that small chamber, as I have illustrated here on the left, given ventricular status, even though it was hypoplastic and rudimentary and lacking its inlet component. Both of these examples here I show you have a ventricular septal defect. And the problem with this approach can be illustrated when you look at these two hearts, one with classical type of tricuspid valve atresia on the left and the other with a double inlet left ventricle on the left. The similarities in these two cases are that they both have concordant ventriculo-arterial connections. The case with the double inlet left ventricle, also known as the Holmes heart. And this heart with the double inlet left ventricle, that right ventricular chamber, that rudimentary and incomplete chamber, was denied ventricular status. But you can all see that the ventricles look very much the same and almost are indistinguishable. Though what they have in similarity is that both have dominant left ventricles. And if we look at the arrangement in both of these specimens with the dominant left ventricle, the differences are that in the double inlet left ventricle, you can see there are two atrioventricular valvar connections. And with the classic type of tricuspid atresia, there's an absent right atrioventricular connection, both hearts with a dominant left ventricle. You can see in the tricuspid valve atresia that there's a prominent eustachian valve there, and you can see the right coronary within that deep fibrofatty tissue plane at the right atrioventricular groove where the connection is absent. So just another quick mention that you can also have tricuspid valve atresia when you have an imperforate tricuspid valve. In this case, the right ventricle will be hypoplastic and the tricuspid valve is there, but is imperforate. The difference between these two cases is that with tricuspid valve being imperforate, there is a potential for an atrioventricular connection, whereas with tricuspid valve atresia of the classical type, there's an absent connection and no potential for a connection. But both of these produce the same physiological effect. So if we consider the variations at the atrioventricular junction, we have to look at those hearts that have atrioventricular connections that are supported by only one ventricle, those that have biventricular atrioventricular connections that can be concordant, discordant, or mixed in those cases that have either right or left isomerism, or we have to look at the very rare cases that I have pictured here, where you have absence of one atrioventricular connection. In this case, it's the right atrioventricular connection, with straddling and overriding of the solitary atrioventricular valve. So this is known as a uniatrial but biventricular connection, and these are quite rare. So when we talk about double inlet ventricle, it's one type of univentricular atrioventricular connection. Usually there are separate right and left atrioventricular valves, but you can have a common atrioventricular junction with this arrangement. It's always a functionally univentricular heart, and we must assess the ventricular morphology for whether we have a dominant morphologically left ventricle or dominant morphologically right ventricle. Is that chamber solitary and indeterminate? We also must assess the ventricular arterial connections and describe the associated malformations. So if we look at those hearts that have a double inlet left ventricle, they typically have ventricular arterial connections that are discordant or with transposition. But as we saw, you can have the Holmes heart with concordant ventricular arterial connections. These hearts have a ventricular septal defect that's muscular and typically within the outlet component of the ventricles, and they can be restrictive. And in this specimen that I have here, it was a very restrictive defect, and this case did have an interrupted aortic arch as well. You can have two atrioventricular valves to the left ventricle, as well as a common atrioventricular junction. And typically those two atrioventricular valves resemble a morphologically mitral valve. The atrioventricular valves can straddle, as you see here in this four-chamber view. They can be stenotic or even imperforate. It's important to describe the incomplete and rudimentary right ventricle with its coarse apical trabeculations that usually supports the aorta and also can give rise to both arterial trunks or have a double outlet right ventricle. And this hypoplastic and incomplete rudimentary right ventricle is typically on the anterior superior shoulder of the heart. You can have a double inlet right ventricle, and this typically occurs with a common atrioventricular valve, as we see here. And this was the so-called primum type of common atrioventricular junction, where the bridging leaflets were adherent to the crest of the septum, eliminating any blood flow into that slit-like hypoplastic left ventricle. And you'll note that there's no endocardial fibroelastosis in that small left ventricle. You can have two atrioventricular valves, and in this case, you usually will have a double outlet right ventricle or transposition. Having concordant ventricular arterial connections with a double inlet right ventricle is quite rare. The incomplete and rudimentary left ventricle is most often only with its apical trabecular component. And here you can see the right ventricle opened in clamshell fashion with a right atrioventricular valve and a left atrioventricular valve that's mostly committed to the right ventricle. There is a double outlet, and The outlet septum is between the two arterial trunks that are both supported by complete muscular infundibulums. And here you can see that tiny left ventricle on the posterior inferior aspect of the heart, or as Professor Anderson likes to call it, on the hip pocket of the heart. And it only had an apical trabecular component as the mitral valve straddled into the right ventricle and was adherent or imperforate over the crest of the ventricular septum with where it would have communicated with the left ventricle. Now, if we move on to talk about hypoplastic left heart syndrome, we can see I have listed here the 3 different phenotypic variations: mitral stenosis, aortic stenosis, mitral stenosis, aortic atresia, and mitral atresia, aortic atresia. And in both of the first 2 images, you can see there's a tiny mitral valve with mitral stenosis, and in the far right image that there's a dimple at the floor of the left atrium where there is mitral atresia. In the hearts with stenosis, you can see the unicuspid unicommissural aortic valve in this case. Then there are multiple variations we can see at the aortic valve or within the aortic root. And in this middle picture, there's aortic atresia along with the mitral stenosis. And in the right image, there is a slit-like left ventricle with no endocardial fiber elastosis, and there was aortic atresia. There's also another 4th phenotype that's been described, the so-called hypoplastic left heart complex. And in this variation, we can see that all components within the left ventricle are proportionately small. And there are varying degrees of endocardial fiber elastosis and as well ventricular hypertrophy. All of these hearts have a fairly good-sized left ventricle that doesn't quite reach the apex. And if you look from left to right, you can see the varying degrees in hypertrophy of the left ventricle as well as the endocardial fiber elastosis. So with hypoplastic left heart syndrome, you always have an intact ventricular septum with concordant atrioventricular and ventriculo-arterial connections. The right ventricle is the dominant ventricle and typically forms the apex of the heart. There are variations at the atrial septum, at the atrioventricular junction, and at the ventriculo-arterial junction. And many of these specimens will have an associated coarctation. The specimens that have the phenotype with mitral stenosis, aortic atresia, are those that typically have coronary artery to left ventricular fistulas. We did recently publish a large series in 2018 where we looked at the coronary artery anomalies in hypoplastic left heart syndrome, and there can be other anomalies other than just the fistulous connections. So there's variation at the atrioventricular junction, and here you can see a relatively good size mitral valve. Even though it's stenotic, it has a relatively normally formed valvar apparatus. You can see very tiny mitral valves with fused tendinous cords, and even this one has a portion of the mural leaflet fused to the underlying endocardial surface. You can see arcade or hammock malformations, solitary papillary muscle or parachute malformation, and at the mitral valve, you can also see imperforate valvar apparatus, and you can see the one at the top is much smaller than the one at the bottom. So this just shows us that the insult during fetal development was later in one rather than the other. And then we can see that specimen that I showed you before with the absent connection at the left atrioventricular junction. There's also variation within the ventricles. So those within the group that have mitral stenosis, aortic stenosis, can have globular, very hypertrophied ventricles with varying degrees of endocardial fiber elastosis. Those with mitral stenosis, aortic atresia also can have some variation in the ventricular size. The ventricles are typically globular and do not reach the apex of the heart. And those with mitral atresia and aortic atresia typically have slit-like ventricles. You can see the varying degree in size of all of these 3 ventricles, and they do not have endocardial fiber elastosis. The very bottom image shows us some other complications we can see existing within this group of hypoplastic left heart syndrome. When you have premature closure of the oval foramen, you can end up with a very dilated flat valve at the floor of the oval fossa. And the first two phenotypic groups that I have listed here are those that have endocardial fibroelastosis. And again, this can be to varying degrees. When we look at the variation at the ventricular arterial junction, what I want to point out is how do we get from the top image to the bottom image, where we have a relatively good-sized aorta, to this very tiny hypoplastic ascending aorta that basically serves as a conduit for the coronary arterial circulation. So if we look at how these things may proceed during development at the aortic root, we can see that we have unicuspid and unicommissural valves that can also have a degree of added dysplasia causing stenosis. You can have bicuspid thickened aortic valves that have a very tiny luminal outlet. These bicuspid or unicuspid valves, for that matter, can progress to become imperforate. This one shows us a very tiny left ventricle with a unicuspid unicommissural valve that became imperforate, and you can see where the only complete interleaflet triangle is marked with the red arrow, and we can progress to that tiny aorta where we have a blind-ending aortic root. So these are just some of the variations we can see, and also shows us where the insults during fetal development may have occurred. So to move on with the last functionally univentricular heart I'm going to talk about is to look at pulmonary atresia intact ventricular septum. And in this group, there is a spectrum of severity, and in between the favorable, the intermediate, and the severe types, there is a very wide spectrum that we can see. So with the most favorable type, there's minimal hypoplasia of all the ventricular components, and the right ventricle is usually tripartite. The subpulmonary outlet component is typically patent, and the pulmonary outflow is typically blocked by an imperforate valve. You can see in the top image, we have a well-formed apical trabecular component, and the tricuspid valve opening is of good size, but it is quite dysplastic. So this can cause additional issues with even the most favorable type. The pulmonary valves in this favorable spectrum, even though they're imperforate, are good candidates for a valvotomy. And you can see in the bottom image, there was an imperforate valve that did have a perforation in the cath lab. In the intermediate type, this is the group where you can have a wide variation of mural hypertrophy within the ventricles. The subpulmonary muscular infundibulum is typically recognizable, but has a muscular roof. The pulmonary artery, as you see in the bottom image, is usually with tri-radiating blind-ending sinuses. The apical trabecular component in this group is obliterated by mural hypertrophy of the apical musculature, and the tricuspid valve has varying degrees of stenosis and even varying degrees of dysplasia. These ventricles are usually bipartite, so they have an inlet and an outlet component that are recognizable. This group can also be complicated by fistulous communications between the coronary arteries and the right ventricle. And in this particular case, there was an associated vestibular atrial septal defect. The most severe or least favorable type, the outlet component and the apical trabecular component are typically obliterated by that muscular or mural hypertrophy. The ventricular cavity is typically only represented by the inlet component, and the tricuspid valve is typically markedly hypoplastic and can even be dysplastic. These are called unipartite ventricles because they only have an inlet component. And incidentally, within this group of pulmonary atresia intact ventricular septum, you can see varying degrees of Epstein's malformation as well. These cases are typically complicated by fistulous communications between the coronary arteries and the right ventricles. And if we look at this area that I have in the red box a little bit closer, we can see that the insult in fetal life took place very early because the pulmonary trunk is this thin thread-like fibrous strand. The circumflex and the anterior interventricular coronary arteries are dilated because they have coronary artery to right ventricular fistulas. And then you can see a very dilated right coronary orifice proximally and a very dilated right coronary artery. And you can compare that to the fistulous communications I have pointed out in the upper images. So some final thoughts. These patients with hearts falling into this group are mostly converted to the Fontan-Kreutzer circulation to allow these patients to survive. Adequate description of the ventricle or ventricles, along with the atrioventricular and ventricular arterial connections, is a required thing for both the clinicians and the morphologist or the pathologist. And when we utilize sequential segmental analysis along with the morphologic method, this allows us for complete description or diagnosis that we can all understand. Even the patients these days or the families can understand what we're all talking about. So thank you very much for your attention.